Today is World NTD Day. Unite, act, eliminate NTDs. For millions of people, neglected tropical diseases are synonymous with diseases they have been suffering for decades. Conditions that cause stigma, discrimination, and mental health challenges. For others, NTDs mean the loss of a loved one, or the underlying reason why they have HIV, or outbreaks that pose a constant threat to their communities. However, for many millions more, NTDs are synonymous with hope. Hope that they will no longer have to suffer from these conditions because their governments, together with partners, fought the good fight and succeeded in eliminating NTDs. As Dr. Yao Sodalon often says, we can no longer see river blindness in our communities thanks to Mectism. For all of us gathered here today, NTDs are also synonymous with threat. We are concerned that years of progress and success could be jeopardized by an increasingly fragmented post-COVID world and the declining prioritization of NTDs both by governments and donors, leaving communities on their own. A high-level meeting of NTD stakeholders last year emphasized the need to work collectively in new and different ways to sustain and build on remarkable progress achieved over the past 2 decades. This requires supporting country leadership, elevating NTDs as national health priorities, integrating NTDs into national health systems, and adopting innovative delivery and financing approaches. This is why we are here today. We will explore how integrating the planning, delivery, and monitoring of NTD interventions within the broader health system into primary healthcare systems can strengthen sustainability, resilience, and reach. Dr. Elizabeth Juma said it very clearly on Afro webinar on Wednesday. Leadership is the key to successful integration. NTD integration means embedding NTD services within national health systems rather than running them as standalone programs. From a health systems lenses, integration implies breaking down program silos by assimilating disease-specific planning, financing, implementation, and service delivery into the comprehensive health services and public health functions. Integration is not merely just co-delivery of services at the country level. It implies system transformation. Integration also extends beyond health sector, linking NTD efforts with water, sanitation, nutrition, vector control, and education. Strong, integrated, nationally owned supply chains are also critical to ensure the medicines and the diagnostics reach all communities efficiently. We will learn from 9 countries that are here with us across the globe that will showcase of practical approaches to NTD integration. And now, it is my great pleasure to introduce to you our keynote speaker, here from the house, from WHO, Dr. Daniel Ngamije. He's the director of the Malaria and the NTD department at WHO. He is the former Minister of Health in Rwanda. He was a champion in his own country, and he's now a global champion for all of us in the fight and elimination of NTDs and malaria. Daniel, a warm welcome. The floor is yours.
Thank you, Maria, for these kind words. Distinguished panelists, esteemed colleagues, partners, and friends, it is my great pleasure to welcome you to this webinar. Happy NTD Days, our day. Thank you for joining us from across regions and sectors and for your continued support for advancing the elimination of NTDs. We are here to celebrate success. Just to recall that on this World NTD Day, we celebrate achievement driven by country leadership, ownership, but also effective partnership for sustained commitment. As early 2026, 58 countries have eliminated at least one NTD, making significant progress toward WHO global target of 100 countries by 2030, reaching elimination of at least one NTD. These achievements show that NTD elimination is possible when at the same time and collectively, countries lead in assuring effective NTD integration in all critical dimensions of it. But also countries invest strategically in health systems, enabling performance of core functions such as planning and budgeting for access to health services, quality of care, data systems, human resources, and well-functioning supply chain. And finally, elimination is possible when countries follow a clear evidence-based pathway to inform NTDs policy adoption and effective implementation. WHO NTD Roadmap 21-2030 continues to guide countries towards NTDs elimination goal, providing a strategic framework for planning, implementation, and monitoring NTD burden trends to inform further strategic investment in health sector and other sectors, and particularly in NTDs interventions with partner support for optimized impact. Regarding the importance of integration, which is the theme of our webinar, which is also pillar 2 element, as we all recall, in the strategy for roadmap or for NTD roadmap. Let us recall that integration operates when countries are increasingly, integration is conducted today when countries are operating in increasingly complex public health and financing environment. Therefore, making integrated approaches for NTDs services is both timely and necessary. Integration goes beyond just an operational option. It's a strategic choice that enables efficient delivery of NTDs and multi-disease services, responsiveness to evolving priorities, and contribute to enhance health systems resilience. Mainstreaming NTDs within health systems is critical and impactful when embedded in routine health sector structures and processes, rather than remaining consistently implemented as a parallel efforts. By reducing progressive reliance on external health financing aid, integrated and country-led approaches place national ownership at the center of sustainable progress. Integration brings benefit to all main actors in health systems actors. For beneficiaries of services, integration improved continuity of care and easier navigation of services, assuring access to preventive and care services over the time. For providers, we observe greater coordination across NTDs and other health programs through aligned management systems, shared financing mechanisms and logistics, and joint monitoring and evaluation of programs. And for decision makers, integration contributes to reduce fragmentation and improves coherence in decision-making by strengthening governance and planning across public, private, and voluntary actors for a real multi-sectoral response. Having the integration contributing to the sustaining and extending gains in the best way to value previous and ongoing investment for NTDs. At the time of budgeting constraint and fragmentation, countries should shift from single NTD program approach to an integrated operating model, contributing to more resilient health systems, inclusive and equitable. The elimination of NTDs is a shared global responsibility, requiring collaboration among all stakeholders. The most important question is no longer whether NTDs can be addressed, but how gains can be sustained and extended equitably over time. Now, in all this process of assuring NTD integration, the main question should also be, what is the role of WHO? WHO remains committed to providing normative guidance, convening partners, and supporting countries to integrate NTD services within broader health systems in alignment with national priorities. Through technical assistance, evidence generation, global coordination, WHO helps countries to translate its guidance on integration into sustainable actions with measurable impact. The global health landscape is shifting, traditional models of cooperation are dissolving, and we must recognize that the old world we once knew will not return. This is unfortunately the reality. In recent years, even currently, WHO is transforming how it operates, redesigning its processes across planning, data, policy dialogue, and innovation to be fit for purpose in this unpredictable world. This transformation is not only organizational but also cultural, breaking down silos, integrating disease-specific efforts with broader determinants of health, and building one cohesive WHO. These reforms ensure that WHO remains the authoritative, agile, and coherent voice in global health, capable of supporting countries meaningfully. Looking ahead while closing my remarks, these are key messages I want to share with you. By strengthening integrated, country-led approaches, we can sustain hard-won NTDs gains. We can also reduce vulnerability, enhance resilience to funding shocks and other emerging threats. And finally, we can accelerate progress toward a world free of NTDs. I wish you a successful webinar, rich discussions, inspiring exchange that will help to shape the next phase of our collective journey. Thank you, colleagues, for your dedication, your leadership, and your partnership. Happy to work with you. Thank you.
And thank you so much, Daniel, for this important message. Let's listen now to the experience of the Ministries of Health. Dr. Pauline Mouensi from ESPEN, who is here with us today, said on Wednesday that each country has to tailor their approach to integration to their local context, values, and preferences. Not everything needs to be integrated. And a practical start point to integration is to identify first what is the root that is causing the fragmentation, such as single disease funding, governance structures, long-term objectives, and then integration of what, with what, and how. It is important to understand that the overall national health system needs to be understood, and the placement of these disease-specific components within it, how they are going to fit, including the extent to which the system is aligned to the primary healthcare approach. We are going to talk to Niger. Niger offers a strong example of what sustained country-led integration can achieve. Since 2007, Niger has implemented a fully integrated national mass drug administration campaign targeting multiple entities simultaneously by pooling financial, human, and logistical resources across programs. This approach has delivered impressive results. Dr. Salisu Adamu from Niger, what lessons from Niger experience would you highlight? And please use the interpretation channels to all the Anglophones out there that don't speak French.
L'intégration des activités de lutte contre les MTN dans le système de santé au Niger. Je suis le docteur Salisu Adamou, le coordinateur du programme national de lutte contre les filarioses et l'onchocercose. L'intégration des activités a une longue histoire au Niger. Dès les années 87, avec le contrôle de l'onchocercose comme problème de santé publique, l'intégration des activités des autres pathologies qui n'ont pas été prises en charge a été intégrée à la surveillance de l'onchocercose. Je voudrais parler de la schisto du ver de Guinée et cela grâce à un long réseau d'agents de santé communautaires disponibles au niveau du programme. Nous avons deux approches pour l'intégration. D'abord, l'intégration des activités pendant le traitement de masse. Et une nouvelle approche d'intégration, celle de la surveillance post-élimination de l'onchocercose. Pour ce qui concerne l'activité de traitement de masse, nous mettons cette intégration parce qu'il est nécessaire de mettre en commun les différentes ressources disponibles, que ce soit les ressources humaines, financières, matérielles. Leur mise en commun nous permet d'avoir un optimum de moyens pour mettre en œuvre le TDM par une même équipe au même moment avec la même logistique. Ce qui nous permet de gérer les ressources humaines, matérielles et financières et d'économiser le temps des agents de santé pour une bonne performance en termes de couverture géographique et même thérapeutique. Les étapes de la mise en place donc de cette intégration se fait à travers la même micro-planification, la même commande de médicaments, la même formation des agents de terrain avec le même module intégré, la même équipe de mobilisation sociale fait toutes les molécules, donc pour tous les 5 MTN en charge donc qui sont à chimiothérapie couverture. Nous faisons un lancement de la campagne par la même équipe la même équipe, donc composée par les hautes autorités du ministère de la Santé publique. Nous faisons aussi la distribution par le même agent de santé communautaire, celui qui donne les paquets pour le trachome, la filariose, l'onchocercose, celui qui donne le même paquet au même moment, et les évaluations se font ensemble pour les 5 MTN et l'année aussi de la supervision. Tout est intégré en matière de mise en œuvre de cette activité de campagne de traitement que nous avons commencé au Niger depuis 2007. Grâce à ce long réseau de brigadiers villageois, au-delà de la distribution communautaire des médicaments, nous sommes maintenant dans une nouvelle approche, l'approche de la surveillance continue post-éliminatoire de l'onchocercose, dans le but donc de détecter précocement de cas. Cette nouvelle approche nous l'avons décidé parce qu'il est important pour nous, après l'élimination, de nous inscrire dans la durée. Et le fait que cette approche nous a permis déjà l'intégration des activités de surveillance onco dans les activités transfrontalières de routine que les districts ont l'habitude de faire. Et nous a permis de nous intégrer aux activités de vaccination. Nous avons intégré les activités de surveillance post-ordination aussi aux sorties foraines et même les activités de sensibilisation qui sont organisées par les autorités politiques et sanitaires au niveau des districts sanitaires frontaliers qui sont même en dehors de la zone connue onco, sont actuellement acquis et sont en train de se faire. Les avantages de cette intégration sont multiples parce qu'en termes, nous avons une réduction de coûts, une facilité de coordination, une amélioration du service et une meilleure couverture donc de l'offre de soins. Elle facilite l'adhésion des partenaires et une meilleure mobilisation des ressources. Elle permet une utilisation optimum des ressources financières, favorise l'harmonisation des interventions des partenaires, permet un gain de temps. Mais cela ne se fait pas sans difficulté. Comme difficulté, nous avons un retard donc dans le retard de la mise en œuvre de la logistique est un important facteur qui limite une très bonne intégration. Parce que souvent, les commandes de médicaments ne viennent pas en même temps. Nous avons souvent une surcharge de travail pour l'agent de santé communautaire, qui est le seul pour pratiquement toutes les maladies, tous les programmes, en dehors même des programmes MTN. Nous avons aussi certaines spécificités de certains programmes qui sont compromises. Le fait que souvent les pathologies ne se trouvent pas dans le même district sanitaire. Il y a une inégalité dans la répartition donc géographique de certaines pathologies comme l'onco et la schisto entrave l'uniformité dans la stratégie en termes d'utilisation des mêmes ressources matérielles et même humaines après l'information. Je vous remercie beaucoup.
Thank you so much, Dr. Salisu. We are moving now to Ethiopia. Ethiopia is making exciting strides in the integrated health campaigns through their electronic collaborative action strategy, ICAS. Since piloting in 2024, the country has finalized the framework, launched regional microplanning, integrate campaigns, and established strong leadership engagement at both national and regional levels. We have with us Mr. Jonas Sula, Senior Technical Advisor at the Federal Ministry of Health, Ethiopia. Mr. Sula, what lessons can we learn from Ethiopia? What can be useful for other countries?
Hi everyone, my name is Jonas. On behalf of Lendisa Manet, the Senior Advisor to State Ministers, I will be presenting ICAS on integrated health campaigns. Millions of Ethiopians are impacted by preventable diseases, including zero-dose children, malaria, NTD, NCT. And on average, around 40 campaigns were conducted every year, and most of them were not integrated. So these non-integrations brought duplication of efforts, overburden to the health workers, and also fatigue to the communities, while wasting scarce resources. This is, the average campaigns that were conducted since 2019 to 2025. So the solution was, the ICAS. ICAS was adopted by Ministry of Health and aiming to catalyze partners to institutionalize campaign coordination and integration to enhance campaign effectiveness and build a more effective and coordinated health systems. What we achieved so far is, since opt-in in 2024, we did, establishing National Steering Committee, TWGs, and also we developed the strategy, and we have conducted, assessments, and We did the first integrated health campaigns on measles IA, and also now we are doing integrated onco-MD distributions, malaria ITN distributions, and also hypertension and eye problem screening. Coming to the ICAS governance structure, we have a NACC, National Steering Committee, technical working groups, national coordination teams, and also regional coordination team. We did campaign characterizations based on their target groups, geography. So we selected, 5 groups of campaigns: fixed site, house to house, school-based, and community-based one. When we do this, we try to look at, the intervention compatibility, point of delivery, timing, flexibility, HR, and geography. The 2026 integrated onco-immediate distributions, malaria ITN, hypertension, and eye problem screenings. This was nationally launched in the presence of, His Excellency. You can look at it, some of the pictures. The geographic sites are, 42 districts where the 3 campaigns are integrated, and 263, where MDA and NCD screening conducted. This is the co-delivery models at the committee levels. We have MDA distribution teams, ITN distribution teams, and clinical teams. This integration campaign is conducted at the community level, village level approach, and the interventions are ivermectin distributions, LLIN distributions, and also the blood pressure measurement and eye problem screening. The integration points are community mobilizations and citations, data collections, scheduling, to maximize village level service provisions, joint support supervision, and the quality assurance. When we conduct every integrated campaigns, I think we need to look at these 5 areas carefully: the coordinations, the advocacy social mobilizations, the training, the logistics, especially the last mile distributions, the monitoring and evaluation, especially the use of real-time data using digital platforms. The campaign progress until January 27, we have distributed MD ivermectins for 70.4 millions, ITN distributions for 1.3 million ITN distributed, 2.1 million individuals screened for eye problems, 930,000 individuals screened for hypertensions. The key lesson learned: strategic lead time, structured governance, logistic optimization, agile monitoring, sustainable financing, and digital integrations are very important. These are some of campaign action photos. I thank you.
Thank you so much for sharing those important lessons learned from Ethiopia. We are now traveling to Egypt. Egypt progress offers valuable insight in how NTD programs can move beyond vertical approaches and become part of the routine national health systems. Dr. Ahmed El-Birri, I would like first to ask you about Egypt's experience into integrating NTD services and surveillance. What policy and system changes made it possible? And also, when you look ahead, now that Egypt is shifting from elimination to sustaining the gains, what lessons would you like to share with other countries?
Assalamu alaikum. Hello, good evening, everyone. I am Dr. Ahmed El-Birri, General Director of Tropical Disease Department, Ministry of Health and Population, Egypt. I am very happy to be with you in this meeting in the Day of the World Neglected Tropical Disease, and I hope every country in the world eliminate neglected tropical disease in the future. Egypt now has a certificate of lymphatic filariasis and trachoma, and 0 cases of leishmaniasis and the control of ectoleishmaniasis, and send a dossier of SHIS2 as public health block. As the vision of the General Department of Tropical Diseases is prevention of reintroduction of certified diseases and reducing the burden of other neglected tropical diseases. Also, elimination of systemizes as a public health problem and rehabilitation of chronic filariasis cases. Egypt's success to maintain a strong surveillance strategy for tropical diseases. As Egypt has a very good experience in neglected tropical disease surveillance. Egypt work many times for surveillance, passive, active, event-based surveillance centers and sentinel surveillance. Also, all neglected tropical diseases integrated in the National Surveillance System needs the program. This National Electronic Surveillance System allows real-time for monitoring of diseases, data analysis, and rapid response for any event. Also, ongoing evaluation for surveillance system of tropical disease. Second pillar for the strength of the surveillance of the neglected tropical diseases as the Central Department of Tropical Diseases and Vector Control in the Ministry of Health and Population has a multi-sector cooperation with many other ministries, such as agriculture, water resources, irrigation, local development, Ministry of Defense, Ministry of Education, and others. Regular meetings were done for exchange of data and strong surveillance. Also, stakeholders of other organizations such as WHO, African CDC, IOM, and others. Third pillar for the strength of the surveillance of neglected tropical disease is training. Training is very, very important for the strength of the surveillance system. Training for the medical staff for early detection and management. Training for lab technician. Training for surveillance officer. Training for agriculture for vector control. FETB program, Field Epidemiology Training Program, is a very important training for the medical staff and the others work in the public health. Also, Egypt was the first country to conduct vector FETB for agriculture engineering in many ministers working in the vector control. Also, public awareness about neglected tropical disease is one of the most important factors that help to increase the efficiency of surveillance system. This awareness done by integration of all ministers. Ministry of Health in Egypt has a financial growth of medical service budgets from national resources implemented in the national strategy and making optimal use of available resources and dividing independent on a single sources of finding. General Department of Tropical Diseases have many initiatives to improve quality of the health system, such as systemizes inventors and the multi-structural cooperation with the national stakeholders improve the quality of health system and the elimination of the neglected tropical disease. At the end, thank you for your attention.
Thank you for these important insights from Egypt. Let's move now to the Republic of Congo, a country that is actually very close to my heart. I used to live there for several years, and I am also a proud mother of 3 Congolese children. Dr. Emile Mbolo, can you tell us about your exciting story in the Republic of the Congo, how Congo fully mainstream its onchocerciasis NDA into the national NTD program and the broader health system? Is this approach more cost efficient? Has it increased sustainability? And what can we learn?
Merci à tout le monde. Merci, Dr. Maria, pour la parole. Je suis le docteur Émile Mbolo Marlon. Je suis le directeur du programme national de lutte contre l'onchocercose, filaire lymphatique et JONMTH en République du Congo. Permettez que nous partageons l'expérience sur l'intégration progressive de nos activités dans le système national de santé. Il faut dire que l'intégration progressive de l'administration de masse de médicaments contre l'onchocercose au sein du système national de santé constitue un levier majeur d'amélioration de l'efficacité opérationnelle de notre programme. Alors, sur le plan opérationnel, cette intégration a permis l'utilisation des structures existantes de la pyramide sanitaire, en l'occurrence les districts sanitaires et les aires de santé, pour la planification, la mise en œuvre et la supervision des campagnes de traitement de masse. Mais elle a aussi permis une meilleure coordination entre le niveau national, en l'occurrence le programme, en passant par le niveau intermédiaire et le niveau périphérique, en réduisant bien sûr le chevauchement des activités et le coût logistique. Et cette intégration a permis également l'alignement des activités de traitement de masse sur les cycles de planification annuels des districts sanitaires, y compris des aires de santé. Alors, sur le plan de la pérennité, l'intégration a favorisé, entre autres, l'appropriation du programme par les autorités, au-delà de la considération de projets dépendant exclusivement des partenaires. Et donc, cette appropriation des autorités, et bien sûr, a favorisé la mobilisation des ressources domestiques pour apporter un cofinancement aux interventions de lutte contre l'onchocercose. Je vais ouvrir une parenthèse. Vous savez que notre partenaire coordonnateur qui appuie l'onchocercose et fait une fatigue dans le pays de Saint-Saveur le sait bien, que les donateurs ont exigé en 2026 un cofinancement des ressources domestiques. Mais c'est grâce à cette appropriation des autorités et qu'on a pu obtenir sur le minimum du cofinancement exigé par les donateurs. Et donc, on peut aussi dire que la mobilisation et la responsabilisation des agents de santé et des relais communautaires, en l'occurrence des districts communautaires intégrés aux équipes locales, a aussi facilité les choses. Alors, mais cependant, concernant la pérennité, il y a quand même des efforts encore à fournir. Donc, nous disons que des efforts restent encore à consentir sur l'approvisionnement en médicaments afin de garantir la pérennité du programme. Vous le savez, j'imagine que c'est le cas aussi pour d'autres programmes en Afrique, que notre programme dépend encore à 100% de l'appui des partenaires pour l'approvisionnement en médicaments. Or, le médicament, c'est la première ressource pour nos programmes. On peut avoir l'argent, oui, mais si on n'a pas de médicaments, j'avoue, on ne peut rien faire. Mais je fais l'inverse, on peut avoir des médicaments et qu'on n'a pas l'argent ou on a peu d'argent, on peut faire quelque chose. Je dis bien quelque chose. Donc, le médicament, c'est la ressource essentielle, la première ressource. Et quand on revoit le coût, ce que coûtent ces médicaments, c'est quelque chose. Alors, si les programmes arrivent déjà à s'acheter les médicaments, ça va évidemment garantir la durabilité. Mais là, il y a encore beaucoup d'efforts à faire parce que j'imagine que c'est le cas pour d'autres programmes aussi, mais le nôtre dépend encore à 100% des partenaires pour l'approvisionnement en médicaments. Donc voilà ce que je peux dire en ce qui concerne la première question sur la, la contribution de l'intégration de TDM, l'onchocercose, dans le système national de santé. Alors, je peux aussi aborder déjà sur la question suivante qui concerne les leçons qu'on a tirées de cette expérience. Il faut dire que l'expérience congolaise d'intégration et de traitement de malades de l'onchocercose a offert plusieurs enseignements imposables au programme de lutte contre le MTN. Alors, sur la planification, l'intégration des activités MTN dans les plans de travail annuels des 10 sanitaires renforce la cohérence, la redevabilité et la faisabilité opérationnelle. Mais aussi, il y a la micro-planification communautaire adossée au système de santé, améliore la couverture et l'acceptabilité des interventions. Et on peut aussi se pencher sur la gestion des données. Nos données sont gérées dans le système national d'information sanitaire, en l'occurrence dans le DSS2. Mais la gestion de nos données dans ce système-là permet la bonne utilisation et donc la prise de décision via ces données, mais aussi le suivi post-campagne. Et ça permet de visualiser après la campagne tout le travail qu'on a eu à faire à tous les niveaux. Donc, en conclusion, ce que je peux dire, c'est que l'expérience de notre programme montre l'intégration des interventions MTN dans le système national de santé n'est pas seulement une option technique, mais une condition essentielle pour garantir l'efficacité, la résilience et la durabilité des programmes, en particulier dans un contexte de ressources limitées. Voilà ce que je peux dire sur les questions qui m'ont été posées. Merci à vous.
Thank you so much. And we are moving now to Tanzania. Tanzania is leading the way in country-led ownership of NTD programs. I don't know if you follow Dr. Clara Jones in LinkedIn. She's the NTD program manager of the Tanzania, and she's constantly posting fascinating stories of Tanzania's leadership on the fight against NTDs. I actually copy-pasted one of her posts. She says, by integrating NTDs into comprehensive council health plans, the country has empowered 130 councils to run mass drug administration campaigns independently without relying on any external donor funding. A true statement to national leadership, innovation, and sustainability. We have here with us today Dr. Gaze Magembe from the Ministry of Health in Tanzania. Dr. Magembe, what advocacy strategies were most critical in integrating NTDs into Tanzania's comprehensive council health plans?
Yeah. Sorry, Maria, I cannot hear you, but I hope the audience can hear me. Can you hear me?
I can hear you well. Can everybody else hear me?
Yes, I can't hear you, Maria, but
okay.
Oh, you can hear me. Yeah, so briefly, let me share with you the experience from Tanzania. It's unfortunate that I'm traveling, so bear with me. I just have to find some space and speak to you. So in terms of what advocacy strategies we were able to use, one is the high-level political alignment and institutionalization. So NTD interventions are well stipulated in our sustainability plan, which was formulated between the year 2021 and it runs all the way to the year 2026. And within that, this has been allocated as a cross-sectoral coordination whereby different ministries actually are responsible, to plan and spare some budget for all these interventions. But also NTDs is part of our sectoral priorities. If you look at our plan, the 2025-2026 health sector priorities, NTDs also featured there. And this has led to the specific budget allocation, especially at the subnational level where implementation takes place. But also we have placed NTD within the Prime Minister's office. The Prime Minister's office role is to ensure that there's multi-sectoral buy-in at policy level. So these NTDs are now taken care, but not only the Minister of Health, the Minister of Water and Sanitation and other ministries as well. And this has also been scaled down to the subnational levels, whereby they've also integrated in their budgets and plans, because initially NTD was a vertical program, but now it's well integrated within the budget plan. And another very strong thing that we've used for advocacy is data-driven advocacy. Now, if you look at our DHIS2, there's a clear information, which an indicator which is being monitored on NTD. So this actually provides information, but also it gives visibility for the subnational levels to see exactly what is happening in the area of NTD, what is being done well, and what is lagging behind, for them to take appropriate measures. So how has this integration allowed national councils to plan, fund, and implement MDA campaigns independently? One, as I said, is the integration into the comprehensive council health plan, whereby NTD interventions, there is now a council-owned source, that is the subnational level, within their own resource allocation from their council's resource collection. They also allocate a budget line for NTD, but also integrated in implementation, as my colleagues have said, during integrated mass drug administration, vitamin A campaigns. And it means that you use the same resources, whether it's transport, logistic, and all other logistic community health workers. They use the very same resources that are used for other interventions to also support NTD. And the other one is leveraging community resources, as I said. So currently, we are using community health workers who are being paid for so many other, they're doing community intervention for so many other interventions, including child health, nutrition. So they are also taking along with NTDs in the communities. But initially, it was completely donor funded. So now it is well integrated. When community health workers go in the community, they also advocate for NTDs, but also they teach communities, and especially on prevention, but also try to find out those people who have got signs and symptoms and refer them to health facilities. So what are the key success factors, if I may share with what has happened in Tanzania? One is that NTD as a program needs to be institutionalized before you socialize. Okay, so what we did was to ensure that NTD is backed into the national planning software. We call it a plan rep. So now it's well institutionalized. But the other thing was data visibility. As I said, data visibility is power, because before that, councils did not know exactly what was their look like when it comes to NTD. NTD infections. So right now they can see, each district can see what is the magnitude of their problem, so they take appropriate actions based on their data. But the other thing is focus on efficiency as a ceiling point. Okay, instead of looking for more resources, we use the very same resources to make sure that the same resources are also used, to make sure that NTD interventions are also taken care, but they are also prioritized. So it was not really about asking for new, but using what is available efficiently to include all interventions, including NTD. And this has enabled us to really leverage on the available resources to increase our coverage in terms of creating awareness, but also interventions. And the other one, which is also very important, is to target administrative, not just the technical lead. This is not only a health issue. It requires resources, especially financial resources. So we went to those, actually, the people who write checks, not just the people who provide services. The services are there, but there are people who sit on their tables and they write checks. The Minister of Finance. So now the Minister of Finance, as I'm speaking in this financial year, they've allocated us almost 4 billion shillings, Tanzanian shillings, which is almost, I would say, 2 million US dollars, okay, which is exclusively allocated for NTD. So it's very important to make sure that our ministries of health, they understand what we are doing, and actually not just understanding, but they also allocate funding to support NTD interventions. And finally is to build the capacity at the local level. That is at the subnational level, because they also have their resources from different local resource revenue intervention that they have in their local communities. So we told them, we don't need you to start by putting a lot. Just start allocating little by little, and then as we move year by year, you'll be increasing the amount depending on the your revenues. So now we have an allocated budget, not only from the central government, but also from the local government, from their own resources. So they allocate, and then the central government sort of like complements what has already been allocated. So I think that's what I can share with you from Tanzania. Thank you.
Oh, that was excellent. Thank you so much. I retain a lot of messages. Data is power. Do what you have and talk to the people that can write checks. I like that one. Thank you so much. We are now traveling very far to Papua New Guinea. We will listen now from Mr. Maron, who will share PNG's progress in the fight against NTDs through integrated community-based approaches. The country has achieved major progress, including validation of trachoma elimination as a public health problem, expanded mass drug administration coverage, and substantial reduction in skin NTDs through integrated service delivery. From Papua New Guinea, Mr. Maron, what has been the biggest enablers to integration?
Good afternoon, all. My name is Abel Marome. I'm the Technical Advisor Leprosy and NTD Program of Papua New Guinea. My presentation today is on integration of NTDs into primary healthcare in Papua New Guinea. Context and the importance of NTD integration. Geographical and operational challenges in Papua New Guinea. Papua New Guinea's geography includes remote islands and mountainous region posing access challenges for health delivery. Linguistic complexity with 800 languages create communication barriers across communities. Health system constraints require integrated approaches for effective control of NTDs. Shifted from vertical to integrated NTD delivery models. Vertical models focus on the disease-specific interventions, often operating independently from general health system. Integrated delivery approach combine multiple NTD interventions within primary healthcare for better resource use. Papua New Guinea has shifted toward integrated NTD delivery to improve efficiency and patient outcome. Implementation of integrated NTD approaches. embedding into NTD interventions into routine health services, integration with outreach services for diseases like lymphatic filariasis, UOS, scabies, brucellosa, and leprosy are incorporated into healthcare workers training, routine outreach, and provincial campaigns. Mass drug administration is used to effectively deliver treatments, reducing duplications, and enhancing coverage. Active case detection platforms identify and manage skin NTDs, improving early interventions and health outcome. Integrated skin NTD approach and its impact. Frontline healthcare workers and community volunteers are trained to identify and manage multiple skin conditions effectively during patient visit. Improved early case detection of skin diseases, including online dermatological consultation, facilitating timely treatment and management for better health outcomes, and reduce stigma in communities and build trust through integrated care and education. Key enablers for integration. National leadership and policy direction. Strong national leadership prioritized health issues and guided national strategic plan for NTD 2025-29 towards achieving desired goal. Prioritization of NTDs. Prioritization of NTD by partners and provincial health authorities. Alignment with universal health coverage goal supports inclusive and equitable healthcare outcomes. Role of community engagement. Community involvement in NTD integration. The role of community leaders for mobilizing communities. Churches as community hub for raising awareness, ensuring adherence to NTD interventions. Civil society organizations facilitate sustained participation through education and support within communities. Outcomes and impact of integration. Demonstrated effectiveness and feasibility in challenging settings. Improved the delivery of neglected tropical diseases interventions through integrated approaches, leading to a reduction in disease burden of skin NTDs in selected provinces, interruption of transmission of lymphatic filariasis in targeted provinces, and national elimination of trachoma as public health problem has been achieved in 2025. Strategic opportunities for scaling up integration. Institutionalizing integration through workforce training and surveillance. Incorporating NTD knowledge in both pre and in-service training enhances workforce capacity and sustainable health integration. Aligning NTD reporting with routine health systems enhances data consistency and accessibility. Leveraging integration for sustainability. Linking NTD interventions with primary healthcare enhances overall program effectiveness and sustainability. Strengthening health workforce capacity supports sustained delivery of health programs and services. Supply chain system ensure consistent availability of medical supplies for long-term health initiatives. Reducing funding dependency on medical funding, promoting long-term resilience. Thank you, and I wish you all a World NTD Day 2026.
Thank you so much for sharing these insights from Papua New Guinea. We are going to hear now from Rwanda. Rwanda, through multi-sectoral coordination, integration with malaria and other disease programs, digital innovations, and embedding mass drug administration into the maternal and child health days, Rwanda has expanded reach, improved efficiency, and strengthened sustainability, setting a remarkable example for other countries. Dr. Aimable Mbitu Jumuremji, Could you share how Rwanda's strong government leadership and multisectoral integration has enabled such impressive progress, and how also using digital tools can improve coverage, data quality, and sustainability?
Thank you, Maria, for the question. Today, Rwanda has made great progress in the context of NTD and malaria control. However, sustaining these gains in the context of external funding decline and the increasing system pressures requires doing things differently. And this line integration is very key, and you can't make it an option, but rather a strategic choice to be made on daily basis if we need to succeed. For Rwanda experience, regarding strong government leadership and multi-sectoral integration to enable progress in reducing the NTD burdens, we can say that Rwanda progress in NTD control is anchored in our strong national leadership by the Ministry of Health first, coordinating all the national effort, but also working closely with its technical agency, the Rwanda Biomedical Center, uh, in which we have our malaria and NTD technical divisions already integrated in one division and coordinated one by one person, the division manager, and having technical staff under this technical division to coordinate all the national effort for malaria NTD control. When you look at what we have so far through this leadership, we can see that we have a joint strategic planning and resource mobilization plan. Aligning with the health sector strategic plan, the technical division coordinating malaria NTDs sit with the different partners, stakeholders, and design a joint strategic plan for NTDs, a joint strategic plan for malaria, and all fund mobilized align with the national priorities. All fund can only be deployed using these national strategic priorities led by the government, not led by the partners. We have integrated procurement and supply chain, but also distribution of commodities as a joint. We can't send one truck for maybe malaria drugs and tomorrow we send another one for MDA tablet, but you do it as integrated distribution. The same for supervisions, trainings, but also mentorship and reporting system. We have all these as part of integrated design nationwide from the community level up to the central level. We have all partners aligned with the government priorities, as I said. We can use Global Fund, WHO, USAID, or any other source of fund to support integrated effort where possible so that we can't maybe send supervision team today focusing on malaria and tomorrow we send another team to focus on NTDs. We try our best to make it happen through integration for efficiency. We have shared human resources, the same community health workers, the same lab technicians, the same teachers, the same healthcare providers can offer integrated services. Even our civil society organizations can support our strategies for community awareness through integrated tools, integrated messages, but also reporting through the same channel. And we can see that integration is also decentralized at different levels, up to district level, health centers, community level, where we can see different disease control provided at each level by the same staff. As a key message, you can say that integration succeeds when it is government owned, but also if it is embedded in the national systems. Thank you for the question around how Rwanda integrating NTD's activities within the other health programs and leveraging tools, mainly digital tools, is improving coverage, but also data quality and the sustainability in our country. I want to share with you that Rwanda integrates NTDs across the entire health systems and service delivery platforms, including integrated coordination, planning, supervision, trainings, but also integrated campaigns, mainly community health workers doing MDA, but also maternal child health week campaign. They are very key. They are the ones also supporting indoor spraying for malaria control, but also bed net distribution nationwide. You can see that integration is very key to make sure that we improve the high coverage. We have the same teachers providing tablets for children in school, but also providing message around malaria control. We have also the supply chain procurement, but also a reporting system that already integrated, and we can see good result. And even as we engage our different stakeholders, local government, Ministry of Education, but also other sectors, including private sector, having this integrated approach helps the programs reach the high coverage because we have those different people on board. This approach has resulted in high MDA coverage so far. We have reached for the STH MDA coverage of more than 95% over the last 10 years, but also the ITN coverage is very high. IRS campaigns reach almost 99% of structures targeted. They are spread, meaning that this kind of integration is very key because the same community health workers, the same teachers, the same local government leaders are the one coordinating all these national efforts. Digital tools play a central role in NTD, where we have indicators integrated in our scorecard, in our HML system, in our reporting tools. We have our scorecard, our dashboard, not only focusing on NTDs, but also including other key indicators from diseases. And using digital system is very easy rather than using paper-based. And today we can see that where we have our community health workers reporting using electronic medical record is now addressing some challenges. And as a final note, we can see that integration works best when countries are the one owning, leading the agenda, aligning partners in different aspects so that we can make synergy. Using a Zinc platform is also very key, like having community health workers, having the HMI system, having campaigns design, but making sure that we integrate them is very key rather than creating totally new things. And investing in digital tools is very key because you can save time, you can save money, but also we avoid duplications and also data quality when you use digital systems. And Rwanda experience shows that NTD integration is achievable, is scalable, but also can be sustained when it is country-led and system-based. Thank you so much for the opportunity.
Thank you so much, Dr. Imabile, and congratulations for your leadership. We are now moving to Madagascar. So for those that don't speak French, be ready to click the interpretation channel. Madagascar offers a standout example of what a smart integration can deliver. By combining lymphatic filariasis NDA with the national polio vaccination program and nutrition campaigns, the country was able to expand reach, increase coverage, and improve efficiency, while at the same time maintaining strong performance across successive campaigns. Dr. Jose Nelly Alphonse, how was this coordination between all these different programs achieved in the practice? And what key strategies contributed to the success of the implementation?
Madagascar fait partie des pays fortement affectés par la filariose lymphatique. Cependant, depuis 2023, le gouvernement, à travers le ministère de la Santé publique, a pris la décision de faire de la lutte contre la filariose une priorité. Ainsi, un plan d'accélération a été mis en place. Cependant, en raison du manque de ressources, ce plan n'allait pas être réalisable. D'où l'idée d'intégrer les campagnes d'administration de masse de médicaments contre la filariose avec la campagne de vaccination contre la poliomyélite. Ce qui a permis de faire une mutualisation de ressources. Le résultat est spectaculaire, si je peux m'exprimer ainsi, parce que pour la première fois, Madagascar a pu atteindre la couverture géographique nationale en matière de campagne d'administration de masse de médicaments contre la filariose lymphatique. En plus de cela, le programme filariose ne disposait que de 200 000 $, mais quand même, il a pu atteindre pour la première fois la couverture géographique nationale, ce qui équivaut à plus de 1 million de dollars d'économie. Comment a été mise en place cette intégration? Cette intégration a été mise en place d'une manière à ce que c'est comme si toute l'équipe du programme est venue se loger dans les locaux de la direction du programme de la vaccination. Je m'explique. Les membres de l'équipe se sont intégrés dans toutes les cellules techniques de mise en œuvre de la campagne polio. Ainsi, tout a été intégré, intégration des finances, intégration de la mobilisation sociale, intégration de la logistique, intégration de la mise en œuvre, intégration de la formation des acteurs clés des deux campagnes. Plus pratiquement, chaque membre de l'équipe donc a travaillé dans les réunions de chaque cellule technique et a participé donc aux réunions hebdomadaires de planification et de mise en œuvre de la campagne polio. Quand même, il faut souligner que ceci n'aurait pas été possible sans un leadership fort au niveau du staff senior du ministère et au niveau de la représentation nationale de l'OMS. Merci.
As he said, spectacular. Very spectacular. Thank you so much. Now we are going to hear from Sudan. We are about to hear about the pioneering initiative launched by Sudan's Federal Ministry of Health in partnership with the University of Khartoum Misetoma Research Center, the Skin NTD Integrated Control and Management Program. This program seeks to integrate the diagnosis and management of skin NTDs into the broader health system while strengthening the capacity across endemic regions, marking an important step toward more comprehensive and sustainable care. Dr. Musa Sihid El Haq, how is Sudan advancing the integrated, patient-centered skin NTD management program within its primary healthcare? What lessons can we learn about treatment, particularly in these remote and conflict-afflicted areas?
Thank you very much, Maria. I hope you are hearing me very well.
Very well.
Thank you. Sorry, I'm not putting my camera on because I'm afraid of the internet connectivity. And I'm happy to speak to you in this very important day for all of us. My name is Musab Siddiq Al-Haj. I'm the PHC Director at the Federal Ministry of Health. And I am proud to announce that I am an old NTDs fighter. I used to be the NTD manager in Sudan. So it's a pleasure actually to address you today in the World NTDs Day. Congratulations all the NTDs fighters and heroes. It's also my pleasure to speak to you from Khartoum, the capital of Sudan. After 2.5 years, we were displaced all over the country. A lot of refugees, a lot of IDPs. You know that when the conflict erupted in 2023, all health programs were severely impacted, and NTD services was not an excuse from this impact of the war. but Sudan had a long history of integration. Actually, when we started the NTDs program in 2013, actually, we tried as much as we could to integrate all entities in one program. Previously, we have many vertical programs, but the first thing we did, we integrate entities itself, and we managed to accomplish and achieve the integrated MDAs campaign. Just the same like the colleagues from Papua New Guinea, the same experience we had here in Sudan. And after the war and all this destruction and displacement of the population, at the Federal Ministry of Health, we work, closely to strengthen patient-centered integrated management of neglected tropical disease by gradually integrating into the primary health care system and the community health services. We were very lucky to launch the Community Health Strategy 2025-2030, and we managed to integrate all the NTDs, prevention, diagnosis, treatment services as a unified package to the community health strategy. We also prioritize the capacity building for health cadres, health workers, and just recently, a total of 62 community health workers were trained in Kassala and Gadarif on case detection of leprosy and visceral leishmaniasis. And we also activate the referral and follow-up system and linking the patient to center providing diagnostic and treatment services. In addition to that, they were trained on the diagnosis and treatment of scabies, dengue fever, and mycetoma. This integration approach in collaboration with the primary health care department contribute to strengthening the efficiency of the national health system, increasing access to service for the most vulnerable population, and improving the quality and sustainability of health intervention. Within the framework of integration, within the primary health care directorate, coordination was carried out with the National Nutritional Program to implement the integrated campaign for children under 5, which include distribution of albendazole for the prevention and treatment of soil-transmitted helminths, where approximately 2.8 million children were reached across 15 states and 105 localities. The integration effort also include coordination between the Directorate of the Universal Health Coverage and the PHC Directorate, benefited from the SHARE project. This is a project responsible for operationalizing about 420 health facilities. We integrate all the NTD services in these facilities. The project is funded, of course, by UNICEF. In addition to that, we also have an integrated campaign with the Vector Control Directorate, particularly in high endemic area, as well as the implementation of health education and community awareness activities alongside health campaign. The experience in the country in implementing the program in remote and war-affected area has generated several important lessons. Most notably, the critical role of local communities in planning and implementing the campaigns. Coordination was undertaken with the local volunteers in inaccessible area to conduct active surveillance for Guinea worm disease in South Darfur state, Redom locality, which is far South Sudan, during the conflict with the routine monthly reporting. Field visits were also conducted after the outbreak of the conflict to assess the availability of the service for the elimination of NTDs and to evaluate the damage sustained by the health facilities providing these services. The experience further underscored the importance of close coordination with the humanitarian and developmental partners. So Sudan now is adopting the Nexus approach and the use of the available data to guide intervention. These lessons will inform the future scale-up of the program in a war-affected area. In this context, coordination has been undertaken with several programs to deliver medicine and laboratory supplies to some war-affected areas, with the procedure currently ongoing to complete this support. Another major achievements include the implementation of integrated skill NTDs campaign. This campaign was funded by the WHO, as well as we have an active case finding activities among internally displaced persons, refugees, and conflict-affected population in 6 states. Future plan include expanding capacity building activities to select to selected conflict affected area in South Kordofan state through training of healthcare workers on the diagnosis and treatment of visceral leishmaniasis in two localities at that state. In conclusion, from the leadership of the Ministry of Health at all levels, including myself, PHC Director, the Undersecretary, and the Federal Minister of Health, to frontline services providers, a unified and sustainable commitment is essential to effectively address all NTDs in Sudan. Thank you very much and congratulations to all of you for the World NTDs Day. Over to you.
Thank you so much, Dr. Musa, for sharing all this, and congratulations to you for all the efforts you are doing for this NTD program in Sudan. We heard from 9 countries, but we know nothing can be achieved alone. That kind of applies both to the professional and the personal world, I think. No? We need strong partnerships and we need strong relationships. So in our next panel, we are going to turn to our partners. And it is a great pleasure to introduce our first panelist, Dr. Isaac Chikangwana, Senior Director of the Infectious Disease Program of the Mohammed bin Zayed Foundation for Humanity, under the visionary leadership of His Highness Sheikh Mohammed bin Zayed Al Nahyan. This foundation has rapidly become a major global health partner in advancing sustainable health solutions and improving lives. Most recently, they led the Reaching the Last Mile initiative, helping to galvanize historic funding commitments and mobilizing hundreds of millions of dollars to accelerate progress towards NTD elimination worldwide. Dr. Isaac, fragmentation, vertical approaches, multiple uncoordinated engagements with countries in the past have weakened health programs and at country level. But the Mohammed bin Zayed Foundation for Humanity is taking a different approach, one that aims to strengthen country ownership. Can you tell us more about it? What model are you using?
Thanks, Maria. Can you hear me clearly?
Very well.
Thank you very much for the question. As Maria has said, I'm Isaac Chikwana from representing the Mohammed bin Zayed Foundation for Humanity. It's a UAE-based philanthropic initiative of His Highness Sheikh Mohammed bin Zayed Al Nahyan, the President of the UAE. So the foundation focuses on 3 strategic pillars: strengthening health systems and workforce, control of communicable diseases, and enabling vulnerable communities to thrive. And across all these pillars, we work with very closely with countries, and we work in partnership with our donor partners. Some of them are represented in this session, and we work in almost the same countries. We have the same partners at country level. We serve the same communities, and we have multiple funding streams. So, for example, for neglected tropical diseases, we have the Reaching the Last Mile Fund that you have mentioned, which is a $600 million fund for the control of for the elimination of onchocerciasis and lymphatic filariasis across the 34 countries in Africa and Yemen. And then we also have the guinea worm disease program that we've been working with the Qatar Center for the last 40 years. And, these are just a few examples of the multiple partnership programs that we have with our partners in all these countries. And I think one of the strategies that we've been pushing for and that would encourage other funding partners like ourselves is really what we've been talking about, which is integration. And I'm saying this from the perspective of a donor because historically one of the barriers that has always been raised against integration has been the ring fencing of donor funding for vertical programming. But in this shrinking fiscal landscape, I think we really need to capitalize and optimize our resources and try to integrate as much as possible. And we've had the experiences from all the countries that are integrating campaigns, not just across NTDs, but across multiple diseases, malaria, EPI, and with all the documented gains and efficiencies that come with integration. And this is something that we are really pushing for as the Mohammed bin Zayed Foundation for Humanity and with our partners through all the programs that we we co-fund together. And I think this is something that we really need to continue pushing for. And that could support, and I think if donors come in, opening up for countries to integrate, it gives countries more flexibility to integrate at country level if we don't put the barriers, around integration. So this is something that we strongly support. Thank you.
Thank you so much, Isaac, and thank you for the long-term commitment to fight NTDs. We are now moving to Site Savers. Dr. Philip Downs from Site Savers, your institution for decades have stood at the forefront of integrated, sustainable NTD action, working hand in hand with governments and communities in more than 30 countries to strengthen health systems, integrate NTD programs into national plans, and deliver life-saving treatments to those in most need. Dr. Phil, what is Site Savers' model to support countries?
Well, first of all, thank you, Maria, for inviting Site Savers to contribute to this important discussion. I think we've heard some wonderful examples that have used the term integration to mean deliberately moving NTD interventions from external donor-funded programs into the government health systems. But this kind of integration is actually quite complex and cannot be a one-off. It has to endure year after year. So from the point of view of an NGO working closely with the government-led NTD control and elimination programs, we see two critical barriers to deeper integration at the country level. First, governments, donors, and partners often define integration differently. We're not always aligned on what we mean or which stakeholders need to be at the table, unfortunately. Second, we underestimate the undertaking of integration, the cost, the time, the process, the level of effort that is needed for systemic integration to take root. Certain NTD programs are actually quite complex and with many attributes that contribute to operational success. So integration of programs isn't just combining implementation activities. It still requires coordination and investment in planning, procurement, training, supervision, reporting, and financial management, things that have been highlighted in the examples today. And not all components can or arguably should be integrated equally or at the same time. As a partner supporting the elimination agenda, Site Savers sees three practical actions that we're trying to support that wider health system. So one, embed an integration mindset into our own program planning from the very start. And to be honest, that can be difficult if the donors are restrictive to even having such discussions. But we need to ask ourselves what attributes of the activities we support can merge with others. So that from procurement to planning, training, social mobilization, reporting, there are a lot of different attributes. And we need to define each one of those attributes of service delivery and their costs. Then let government say which ones they can sustain. Two, support government-led quality reviews after integration happens. We shouldn't just integrate and disappear. We should build the government's confidence and our own confidence through joint learning. And then finally, three, generate evidence. So in addition to this webinar, there's been a number of partners, GON Network, HCE, Glide, just to name a few, that have all produced and shared case studies on integration. I think we all need to read them, reread them, and we need to have more case studies. The IN Lab at Georgetown University, led by Dr. Maggie Baker, recently developed a how to design a protocol for case study research on integration of infectious disease innovations within health systems. Just slips off the tongue. I'd love to drop in the chat a link to that protocol. I think we should all read that guide. We need data, but we need data that's generated from well-designed case studies to drive better decisions, and I think that protocol can help. Just one final thought. I think integration can't be driven by efficiency alone, especially for diseases targeted for elimination. If cost efficiency alone becomes a focus, we do risk leaving behind underserved populations and potentially allowing infections to persist. So sustainability and equity must travel together. It's clear from these conversations that country-led integration is the path forward, but it requires shared definitions, yet flexible ones to fit the context, leadership, not only from government, but also partners and donors, and honest costing and genuine partnership in building the evidence base. So thank you for allowing us to participate in this conversation, and happy World NTD Day.
Thank you, Phil. Those were really, really great insights from SciSavers. And I am delighted to welcome now Dr. Carol Carutu from the MFAN. The MFAN has been a powerful champion for integrated, evidence-based, and cost-effective NTD programs, mobilizing private capital, building strong partnerships that support national disease elimination. Carol, how does the MFAN support countries to build a strong country-owned integrated NTD services that are sustainable and embedded into the health system?
Yeah, good afternoon, everybody from Burundi, where we excitedly today joined the government of Burundi to celebrate validation of having eliminated trachoma as a public health problem. So it's a great way to celebrate World NTD Day. And this question, Maria, that you've asked is so relevant. And I think, well, from the conversations that we've had today from the countries themselves, just played out so well yesterday and today, with government of Burundi just being in the lead, talking to us about everything that they did as a government to get to this milestone. So to answer your question is, as the N Fund, we have in multiple ways been catalyzing the integration of NTD programs into national health systems. And the first thing that we've done is we work very closely with the ministry by supporting them to think through what it means by integration. I think the previous speaker has actually spoken about that. What does it mean? So being very specific, and this is from the planning stage. You don't do this towards the end. You do this from the planning through to implementation and through to monitoring, and at various levels of the health system. So you're looking at district level operational plans through to the national level systems. And it's multiple NTD interventions. And the ways to integrate those are very different. An example is we're very excited, having worked with the Ministry of Health in Kenya and AMREF, our implementing partner, to deliver NTD interventions through the primary healthcare infrastructure. And again, as Phil just said, is the assessment that we did on this showed that the uptake of NTD activities and services was much higher within communities, but even more so, we were seeing a lot higher coverage than we had in the past. We've also been providing technical assistance to national systems to think through. I believe the first speaker, Dr. Gamija, talked about the WHO roadmap and that pillar on integration. This is not something new, but even more so right now, as we think about with countries like Burundi that are talking about, that have eliminated a disease, thinking about integrated surveillance, integrated case management, and also for chemotherapy, when we manage chemotherapy diseases. Then we have to think about data systems. Anything we do, we have to measure. So allowing countries, I think the Tanzanian speaker very well alluded to this, talking about that if you're not able to, if the policymaker doesn't see the data, then they will not prioritize you in funding. So we've been supporting countries thinking about how do you get NTD data well visible within DHIS2 or other systems and showing up in platforms where the ministers and others are, so that they can present that data alongside others. Then finally, when I think about this, not finally, is how do we strengthen the system? Because the system, as we know, we're thinking about 6 elements of health systems. So if you're thinking about the health workforce, if you train a primary health care worker in something that is NTDs, they can use that knowledge when they are in the field delivering something that's nutrition, delivering something that is HIV or malaria. So thinking just about the entire health system, again, supply chain, and I know this is something that we haven't as an NTD sector paid so much attention to because our drugs are donated, but the national health supply chain is one that we need to continue to strengthen, continue to support the monitoring of that and the supervision within the national systems, because NTD drugs, yes, are donated, but the delivery should be through the national health system. Most important to me when I think about long-term sustainability is how do we build the capacity of government? How do we work alongside government? And we do this by prioritizing national leadership. And when I say national, it can be subnational too, in decision making. It is their decision, and then we follow. Then we support with that. We don't even have to think about what we mean by domestic resource mobilization. It's more like together we co-create and work through all the loopholes that are in these systems for very competitive funding that is within the national systems, because even within the national systems, the different ministries, the different departments, the different units are actually competing for money. And then thirdly is we need to work closely with all of us as partners to build resilience, and you do this through cross-sectoral partnerships. It's not just about health, it's about education, it's about WASH, it's about community development sectors, because as we know, NTDs is cross-sectoral. It's not just because of one thing. Then we have to continue promoting adaptive, evidence-driven programming. Without the data, then we cannot make the right decisions, we cannot adapt, and we cannot course correct when we need to so that we can get the largest value for money. Then we have to ensure that integration does not dilute quality. And you do this by starting from the top, as we say. You have to start from the planning stage. You have to think about the policies, and you have to think to the back end again, which is your monitoring and then adapting. So as I conclude is integration is not just a technical shift, it is political, and systems must transform to accommodate the transformation efforts. Sustainability will require that there is shared responsibility. There is the government leading, the partners like us aligning, donors investing in long-term capacity rather than short-term outputs. And then our role as the End Fund, we continue to work with all of you to catalyze the resources that are available out there from the philanthropic partners, so that we can enable communities to build resilient, country-owned systems that can deliver NTD services after we have long left these countries. Thank you.
Thank you so much, Carol. That was super helpful. And we are now honored to welcome to the table Dr. Jordan Tapero from the Gates Foundation. The foundation has been at the forefront of the efforts to eliminate NTDs, and your long-standing commitment and catalytic investment continue to inspire a stronger global action and collaboration. Jordan, we learned that in 20 years, the Gates Foundation will be sunsetting. Can you share with us the Gates Foundation vision for the next 20 years? What directions are you taking in your work to support the leadership of the Global South?
Sure. Thanks, Maria. In January of 2025, Bill Gates gave the foundation both a mandate and a deadline. Looking ahead, the foundation is focused on maximizing its impact through 2045, so for 20 years. This mandate is especially targeting infectious diseases that continue to drive preventable illness, death, and poverty, and NTDs are a core part of that commitment. For NTDs, countries have already shown what's possible. 58 countries have eliminated at least one NTD, including 9 just in the past year, despite a challenging financial environment. That progress reinforces our belief that elimination is truly achievable. For NTDs, the foundation's role is catalytic. We support innovation, the strengthening of systems, and reinforcing country leadership so progress can be sustained long-term. Success won't be measured by how much we fund, but by how well countries are positioned to carry this work forward independently. Across the NTD portfolio, we are increasingly prioritizing partners with strong regional and country presence in Africa. because they're closest to the governments, communities, and long-term delivery systems. Even when working with global organizations, our focus is on reinforcing African leadership, national ownership, and sustainability, including through domestic co-financing approaches that engage ministries of health and finance, as well as efforts to catalyze private sector financing alongside public and philanthropic investment. Would you like me to address the three other topics, or I know we're late on time?
I think what you said was really great, and I really appreciated the thoughts. But we are now going to move to our last speaker, actually, because we heard the importance of medicines for the programs. The Republic of Congo reminded us the importance of medicines, and we are lucky to have with us Marilyn Mainardi from the MSD Foundation. The Mectisan donation program celebrated the delivery of its 5th billion Mectisan in 2025, a truly remarkable achievement. In today's fragmented world, reliable partnerships remain essential for advocacy, strategic planning, and NTD program sustainability. Marilyn, thank you for being here with us. What gives you confidence in the continued strength of partnerships?
Thank you, Maria, for that question and for recognizing what the 5 billionth Mectizan treatment represents. But that milestone is not just about numbers, it's about trust and partnership and commitment. And with this achievement and what it shows is that strong, enduring partnerships can deliver impact at a significant scale over time. Since the launch of the Mectizan donation program in 1987, the program has relied on a broad public-private partnership that includes the WHO, endemic country governments, as you saw today, NGOs, donors, research institutions, and critically, communities themselves. No single actor could have reached hundreds of millions of people year after year. The progress made is the result of the shared leadership and trust among the partners. Our company's commitment created the credibility that enabled others to make their own commitments, but that collective commitment helped move efforts beyond disease control. And today, the river blindness and lymphatic filariasis programs have achieved remarkable progress, with multiple countries reaching elimination milestones once thought impossible. And these partnerships continue to evolve. Endemic countries are co-leaders. The community-directed treatment model has built local capacity and country ownership. And community drug distributors remain the backbone of these efforts, delivering medicine and supporting a wide range of health interventions. The results speak for themselves and shine today on the World Neglected Tropical Disease Day. The examples include 4 countries in the Americas: Colombia, Ecuador, Guatemala, and Mexico, and Niger in Africa, eliminating river blindness. And lymphatic filariasis has seen similar success, with countries including Malawi and Timor-Leste and Togo and Yemen. And these achievements reflect what is possible when governments, industries, NGOs, donors, communities all work together collectively. And it is that shared ownership, the sustained collaboration, and the collective proof of impact that continues to carry these partnerships forward. And that is what gives us the confidence and the continued strength of all these wonderful, critical partnerships. Thank you, Maria.
Thank you so much, Marilyn. And as we conclude today's webinar, we heard from 9 countries with 5 partners, WHO, and I would like to briefly just summarize the key messages from our discussion. Over the past 2 decades, the NTD programs have achieved extraordinary results. I think there is no doubt. They were driven by strong partnerships, sustained commitments, and country engagement. Today's discussions have made clear that the current shifts in the global health financing landscape pose serious risk, particularly for these NTD programs that have been operating in parallel often to the health system. But there is the momentum to present also an opportunity. The speakers have emphasized the need to pivot from vertical to externally driving approaches toward country-owned programs that are integrated into the national health systems. And 4 clear topics and priorities have emerged. The first, that countries must lead, setting their own integration pathways, prioritizing NTDs, and making domestic investments. The second, that partners must pivot, aligning with national plans and acting as catalysts rather than drivers. Third, the NTD services must be embedded within the primary healthcare, the national policies, and the universal healthcare coverage platforms to ensure visibility, efficiency, and resilience. And fourth, financing must become from predictable and sustainable sources, with a stronger domestic resource mobilization, diversified funding models, and external predictable long-term funding to national plans that support them flexibly and promote integration. The decisions being made today will determine whether in the future we sustain the gains and move forward, or we actually risk reversal. Unite, act, eliminate. As the strong community that we are, the NTD community, we can ensure that NTDs are treated not as exceptional programs, but actually as essential services within resilient, country-led health systems. We all have a role to play, so let's play it right. Thank you to all our speakers and to all of you for joining today and for your daily work. And let's make sure that 2026 is the year that we unite, act, and eliminate NTDs. Until next time.
Thank you, Maria.
Bye.
Thank you, Maria, and thank you to all.
Thank you,
Thank you
everyone.
very much to all. See you next time.
Thank you.
All right. Thank you, everyone.